As things stand right now, with all the cumulative knowledge that we have gained in the last many years, the young myeloma patient and at my institution at MD Anderson Cancer Center, which is, of course, based on the cumulative data that have emerged, and that's true for most of the centers in the United States. So a young myeloma patient with good performance status and otherwise in good health and normal organ function, our goal is to do induction treatment followed by autologous stem cell transplant, as they are in general considered transplant eligible, followed by maintenance treatment. In terms of induction treatment, the current accepted norm and the most commonly used combination is VRD, Bortezomib, Lenalidomide, and Dexamethasone. And in general, we try to do about 4 cycles of VRD. Now, at my institution and at other centers, based on some very good phase 2 results, many people started using KRD, replacing Bortezomib with Carfilzomib as induction treatment. But that has been tempered by the results of endurance trial, which compared VRD with KRD head-to-head as induction, although in patients with no intention to proceed to upfront transplant. And that showed that VRD is as effective as KRD, and KRD had more cardiac and pulmonary and renal adverse events. So because of that, at our institution, VRD is still considered the standard of care for induction. This is followed by high-dose chemotherapy and autologous stem cell transplant. And the gold standard for that has been Melphalan 200 milligram per meter square for almost 30 years now. And that regimen is still used for most of our patients. And in the US in general, most patients proceed to a single autologous stem cell transplant. And that is based on the results of the Stamina trial that compared single versus tandem versus transplant, followed by 4 cycles of consolidation, which showed that the main primary outcome, progression-free survival, was the same. So after about 4 cycles of induction, we take our patients to stem cell transplant with Melphalan 200 milligram per meter squared. With one exception at our institution, and some of our other colleagues are doing that based on our phase 3 randomized trial of Busulfan plus Melphalan versus Melphalan, which showed significant improvement in progression-free survival, which was quite pronounced in patients with high-risk chromosomal abnormalities like deletion 17p, translocation 414, translocation 1416, and also amplification of chromosome 1q. So in those patients, if they are eligible and they are younger than 70, we use a conditioning of Busulfan plus Melphalan instead of Melphalan alone. And then after approximately 3 months after transplant, our young patients go on to get maintenance treatment. Again, the most commonly used maintenance treatment is single-agent lenalidomide, based on a number of phase 3 trials, which all showed improvement in progression-free survival, and at least one of them showed improvement in overall survival, which was also seen in a meta-analysis. So then the maintenance treatment with single-agent Revlimid. However, in high-risk patients, where we and others feel that single-agent Revlimid may not be adequate and a proteasome inhibitor is needed, and there are data, especially from Emory University and the original HOVON study in 2012. So we use generally a combination of proteasome inhibitor, either Bortezomib or in some situation, Carfilzomib with lenalidomide as maintenance treatment in our high-risk patients, the same where we try to use Busulfan plus Melphalan as conditioning regimen.